So we have touched on many topics this morning. Welcome back, everyone. And just now also about symptoms control and palliative care in specific population of patients. For this upcoming session, we will put an emphasis on management that can be done at home and also experiences on the process of rapid discharge for end-of-life care. To start off this session, may I invite the next speaker, Dr. Lim Zini. Dr. Lim is a palliative care doctor working with Hospice Malaysia. In Hospice Malaysia, Dr. Lim is involved in daily clinical work, overseeing the clinical team, research, as well as training for doctors, nurses, and medical students. She has completed Masters in Palliative Care from Cardiff and presented her research findings at the World Cancer Congress in the year 2018, as well as at the Conference of the International Society of Advanced Care Planning Rotterdam in the year 2019. She will be giving us a lecture on managing delirium at home. Please welcome Dr. Lim Zini.
Good afternoon, everyone. Before I start, I just want to check that you can see my PowerPoint slides. Sorry, I can't hear anything. Can you see my PowerPoint slide?
Yes, we can see them.
Oh, okay, excellent. Yeah. Sorry, because I can't tell. I can only see my slide in front of me. So first of all, I'd like to thank you to the organizer for inviting me to speak on this topic, managing delirium at home. I think managing delirium in the community is probably one of the more challenging symptoms for the palliative care team. So for this talk, I hope to be able to use a case study to illustrate how we can support patients with delirium and their family caregivers at home, as well as discussing latest evidence to support decision making. Let me first introduce you to Mr. L, who is a 90-year-old gentleman with history of thoracic aneurysm, for which he had a stenting done in 2017 and a restenting just over a year ago. He has a background past medical history of cardiomyopathy, chronic kidney disease, and hypothyroidism. He was admitted into hospital with acute dyspnea and was found to have a bleeding thoracic aneurysm with a large pleural effusion. Both patient and family opted for conservative management, and he was subsequently referred to Hospice Malaysia for palliative care at home. His delirium was initially detected about 2 weeks after the initial assessment, whereby Mr. L's daughter told us about change in his sleep-wake cycle. He will be restless at night, trying to get out of bed, trying to pull and remove his nasal prong. His delirium progressively got worse to a point where he was becoming very agitated and was shouting at night. And this led to significant carer distress. His daughter had to take time off work in order to get some rest. So at this point, how would you manage Mr. L's delirium? Now, I want you to just hold on to your thoughts, and we'll come back to answering this question after going through evidence surrounding management of delirium. Delirium is a neuropsychiatric syndrome that commonly occurs with older age group in people with advanced illness, with or without pre-existing cognitive impairment such as dementia. So it's not surprising that delirium occurrence is much higher in the intensive care unit, geriatric, and palliative care units. Delirium leads to poorer outcome, increased risk of mortality, as well as increased length of hospital stay. Delirium is under-recognized and underdiagnosed by the healthcare team. Delirium in different patient population and setting has different prevalence, causes, natural history, and outcome. So for example, a post-op delirium is distinct from delirium in an older person who's admitted into a medical ward. One of the challenges that we face in palliative care setting is that our patient population is also highly heterogeneous. So managing delirium in a patient with organ failures, as opposed to managing delirium in a patient with progressive disease progression from cancer, can be different. And remember that up to about 49% of patients with advanced cancer, delirium can be reversed. So in any patients who receive palliative care, who presents with delirium, it is important that you always look for possible reversible causes. And it was found that with repeated episodes of delirium, the reversibility of it becomes lesser. In a systematic review across different palliative care settings, the point prevalence of delirium in inpatient palliative care can be as high as up to 74%. It is much lower in the community setting, perhaps because patients are in familiar environment. There are less interventions such as intravenous cannulation. But what they found was across all settings, be it in an inpatient palliative care unit or community setting, the prevalence of delirium increases prior to death, ranging between 42 to 88%. The first step to managing delirium is really for the palliative care team to screen for delirium, to recognize that delirium exists. There are many screening tools out there. On this table, you will see the most frequently studied screening tools in hospitalized patients. For example, confusion assessment method, memorial delirium assessment tool, and so on and so forth. How do we diagnose delirium? This is from the DSM-5 criteria. Delirium is diagnosed when you fulfill this criteria. Number 1 is disturbance in attention and awareness. Number 2, this disturbance develops over a short period of time. That is usually in terms of hours or a few days, and it fluctuates in severity during the course of a day. And with that, an additional disturbance in cognition. There is a requirement that the disturbances seen in criteria A and C are not better explained by an existing or evolving neurocognitive disorder like dementia or comatose state. Studies have shown that delirium has significant impact on patients. In both Bruera and Breitbart studies, whereby they interviewed patients who had resolution of delirium, patients recalled their experience. And of those patients who recalled their delirium experience, 80% or more reported the experience as distressing. And the other thing that Breitbart study highlight was not just patients with hyperactive delirium suffer from the impact of it. We also need to look at patients with hyperactive delirium. They also reported that they were distressed. Delirium evokes strong emotions amongst patients where they feel fearful, confused with not knowing what is happening, disorientated, clouding of thought processes. Delirium also impacts on their communication, impact on how they communicate with people. Patients reported that they felt that they were not being listened to or understood. What about impact on family caregivers? In fact, studies showed that family members are highly distressed and even more distressed compared to patients. Family caregivers reported negative emotions such as feeling anxious, worry, not knowing what's going to happen. And 50% of those family caregivers interviewed expressed that they had difficulty in coping. They felt helpless and exhausted through that experience. Different family caregivers derive different meaning from the delirium episodes. Some misunderstood it as a cause due to drugs. Others interpreted it as part of dying process. And family members found it difficult to cope. Family had to balance the need to relieve suffering, but at the same time, the desire to still want their loved one to be alert so that they can communicate with them. Delirium impacted on their relationship, not just with patient, but also with other family members and medical staff. They reported disagreement and tension when healthcare team and caregivers have different understanding of patients' needs. Family caregivers also fear missed opportunity to say their final goodbyes to their loved ones. Some felt isolated and unsupported by other family members. Now let's dive into the evidence backing non-pharmacological and pharmacological intervention in delirium. In Sharon Inouye's research, it was found that multi-component intervention is effective for prevention of delirium in hospitalized older medical patients. So this multi-component intervention comprised of orientation, therapeutic activities that are cognitively stimulating, sleep hygiene, early mobilization, attention to vision, hearing, and the hydration status of the patients. In her research, she found that once an initial episode of delirium had occurred, this intervention had no significant effect on the severity of delirium. So hence, they conclude that primary prevention is probably the most effective strategy. What about using this in the palliative care population that we serve? Does it really work? There's limited data to support this multi-component intervention. One prospective non-randomized cohort study showed that using this multi-component non-pharmacological intervention targeting physicians, patients, and family did not result in significant difference in the incidence or severity of delirium. In another phase 2 cluster RCT, they found that there was low adherence to multi-component intervention. But in that study, there were no adverse events reported. What about pharmacological intervention? If there's not much evidence to support use of multi-component non-pharmacological intervention, does that mean we are left with pharmacological agents to manage delirium? So the first study was done by Lin and his team in Taiwan, whereby it's an open trial comparing haloperidol with olanzapine for the treatment of delirium in cancer patients. It's a small trial, and the dose of olanzapine that was used was 5 milligram, haloperidol 5 milligram. And what they found in this study was both arms had improvement in delirium, and there was no significant differences between the two arms. The next one is a landmark study, which I believe this audience would be familiar with, which is the study by Mira Agar, looking at the efficacy of oral risperidone, haloperidol, or placebo for symptoms of delirium amongst patients in palliative care. This is quite a large study. And what Mira and her team found was that both arms that received risperidone and haloperidol had greater delirium compared to placebo. And in fact, those who received antipsychotics were more likely to die. Bear in mind that in this group of participants, they had mild to moderate severity in delirium. The next one is by David Hui and his team, which looked at the effect of lorazepam plus haloperidol versus haloperidol alone in agitated delirium in patients with advanced cancer. So this group of participants were already receiving scheduled haloperidol with a dose between 1 to 8 milligram per day, but they continued to have delirium. So one arm received IV lorazepam and IV haloperidol. The other arm received haloperidol plus placebo. What the study found was that the arm that received lorazepam and haloperidol had a greater reduction in agitation. And in the secondary analysis, they also found that caregivers and nurses perceived that this arm of participants were more comfortable. In another study by David Hui, he looked at whether there was any evidence for neuroleptic rotation. So this was neuroleptic rotation for terminal agitation in patients with cancer. So we're looking at patients who are at the end of life. Again, this group of participants were already receiving scheduled haloperidol dose between 1 to 8 milligram. And they were divided into first arm receiving dose escalation of haloperidol 2 milligram intravenously every 4 hours. The second arm was the neuroleptic rotation with chlorpromazine 25 milligram intravenously every 4 hours. And finally, it's the arm that received combination of haloperidol and chlorpromazine, but half the dose. What this study found was all three arms had significant reduction in agitation. A recent Cochrane systematic review looking at drug therapy for delirium in terminally ill adults found that there was a small number of studies and participants, and hence no high-quality evidence to support or refute the use of drug therapy for delirium in terminally ill adults. I have included other studies on pharmacological intervention in other medical settings, which you can refer to in your own time. But let's come back to Mr. L. How can we manage his delirium? So first step is we have to be able to recognize that he is indeed he is indeed having delirium, and I think the tool that I've put up on this slide, confusion assessment method, is quite an easy tool to be used by the clinical team. So with the confusion assessment method, the diagnosis of delirium requires the presence of both features A, which is acute onset and fluctuating cause, and B, which is attention, and the presence of either feature C, which is disorganized thinking, or D, altered level of consciousness. And you can refer again to DSM-5 to diagnose that indeed Mr. L has delirium. The second step is to identify and remove any reversible causes. Of course, you also need to take into consideration the prognosis for Mr. L as well as his goals of care. On this screen, you will see a table by Inouye that basically lists all the precipitating factors that can contribute to delirium in an older adult. So when we look through Mr. L's medication chart, all the medicines that were discharged from hospital could potentially be a precipitating factor. He was discharged with fentanyl 6 microgram, subcut fentanyl 25 microgram, subcut midazolam, and hyoscine butyl bromide. Given that his bleeding thoracic aneurysm was conservatively managed, this meant that his anemia and hypoxia could not be reversed. The third step is support to family caregivers. Studies show that family members want information about delirium, about possible causes, what to expect, and how to treat. And they wanted practical advice on how to respond to their loved ones with delirium. So it's important in this case to sit down with Mr. L's daughter, understand her concerns, giving her information and support her through looking after her father at home. If Mr. L's delirium is mild to moderate, I think there is still a role to use non-pharmacological intervention, but bear in mind you need to consider caregiver factor because in a hospital setting, nurses work in shifts, but in a home setting, Mr. L's daughter is on call 24/7. So some of these activities may become a burden to her. So the next step is looking at, do we introduce pharmacological agent at this point? And if so, what is first choice? I think given that haloperidol is the most commonly evaluated drug in delirium in a palliative care setting, my first choice is still haloperidol because it is available in both oral and subcutaneous formulation. I have not found any studies that compare doses of haloperidol, but in all those studies that I've reviewed, the range of dose is between 1 milligram up to 20 milligrams. So I think a loading dose between 0.5 to 2 milligram is reasonable. So you can start with that and titrate up. With regards to second generation antipsychotics, given that it has better side effect profile, can we consider that? As I have discussed earlier, the studies have not shown superiority of second generation antipsychotics over your first generation antipsychotics such as haloperidol. If you do choose to use the second generation antipsychotic, you need to consider cost, how the patient and family is going to access those drugs from home, and also the route of administration if Mr. L develops dysphagia. And if Mr. L goes into refractory agitated delirium, we can titrate up haloperidol as well as adding in benzodiazepine. And at this point, we will probably use a combination of both haloperidol and midazolam in a syringe driver. I have included this algorithm because I think it gives us a framework to assess and manage delirium in palliative care patients. And again, in your own time, you can go through the algorithm. So as you can see, there is no one-size-fits-all approach to managing delirium. And as healthcare team, we need to constantly weigh the risk and benefit of the treatment of delirium. Our aim is to keep patients as comfortable as possible, but also as awake as patients and their families would like them to be. So in conclusion, there is lack of research evidence in helping us to manage delirium for palliative care patients at home. But just like any dealing with any other symptoms, we have to be patient-centered, and every management has to be individualized to the patient and his or her family caregivers. We need to be able to educate and support family caregivers because they play an essential role in keeping patients comfortable at home. If antipsychotics are needed to manage delirium, start with the lowest possible dose. And remember at all times to balance the sedative effect versus the family and patient's wish to be more awake. So I've come to the end of my talk. And if you have any questions, you can ask during the next Q&A session, but otherwise you can email me as well. Thank you.
Thank you very much, Dr. Limzini. I'm just trying to look in the message box or the Q&A if there's any question. There aren't ones coming up yet for now. But I was just wondering, in your setting, if when patient is at home sometimes and we do use a combination of haloperidol and benzodiazepine sometimes as well and as rescue medication, how do we try and explain to family members when to use which medication exactly? Because sometimes that can get pretty confusing. So just wondering what your experiences are in terms of that.
Yeah. Well, I think before any management is being initiated, assessment, I have to stress the importance of assessment to look at, is this delirium that we're dealing with, or could this be dementia, which is progressively evolving and developing symptoms of psychosis. So first of all is assessment. Now, the evidence basically is gearing us towards using antipsychotic rather than benzodiazepines. David Hui's study basically showed that there is a role for adding in benzodiazepine in patients who has severe agitated delirium. So now I don't really have a black and white answer as to the instructions and the education that we give to family members, because we also need to assess in a home setting whether the intervention is appropriate to the patient and the family caregivers, and whether this family caregiver is able to understand the complexity in dealing with delirium at home. Because many a times family caregivers, they throw me questions like, how do I tell if this is not pain that is causing my father to become agitated? How do I know which to give first? Do I give haloperidol? Do I give morphine? So ultimately, I think is to try to simplify our intervention for patients and family. So in terms of benzodiazepine, I would probably leave it as my second line. I would use haloperidol first, and definitely involve the family caregiver by, so even before the onset of delirium, is to talk to them about the potential development of delirium as a symptom, because again, it's preparing them for knowing what to do. And so I think, yeah, sometimes family members find it very difficult to cope. And even though you've initiated, a management plan to help the patients to be at home, at times we may need to consider a referral to a palliative care unit for carers coping.
Okay, thank you for that. There's another question here by Dr. Lee Can Yu is asking, there is a vast heterogeneity in the dose of haloperidol used in clinical practice, and may I know what is your practice in terms of haloperidol dose before you consider the use of benzodiazepine in the community?
Yeah. So, as I've discussed earlier, I couldn't find any study that compare different doses of haloperidol. But in all those studies that use haloperidol, the range again is a wide range. With Mira Aga's study, she used for elderly patient 0.25 milligram of haloperidol. And some studies used up to 20 milligram of haloperidol. So, I mean, I am a bit more cautious in my approach. I've used up to 10 milligram of haloperidol in the community. And if that doesn't work, then I would consider adding in benzodiazepine.
Okay, thank you for that. And I think we have time for one more question by Yvonne. I tend to find delirium in end-stage renal failure more challenging to manage. Any tips or special consideration that you can share for this group of patients?
Hmm. Yeah, so with patients with end-stage renal failure who develop delirium, again, go back to the stepwise approach, assessment before, you introduce any pharmacological agent. Because as we know, if you look through the list of some of the drugs that could precipitate delirium, all these drugs that we're using to treat delirium can potentially worsen it.
Yeah.
Now, I don't have a magic answer to your question, Yvonne. But if the patient develops worsening delirium, and you have basically looked through all the possible causes and corrected all possible causes, patient still is having persistent agitated delirium, then in this situation, we would use haloperidol again as our first choice to manage it.
Okay. Thank you very much. And thank you very much for all the questions. Thank you very much, Dr. Limzini.
My
Um,
pleasure.
okay, so I think we can move on to the next session.